My name is Judy Wicks, and I work with Dr. Christina Hoban at Columbia University. And I want to welcome everyone who's attending this session, and to also introduce Dr. Milton Wainberg, who is a professor of clinical psychiatry at Columbia University and director of the Mental Wellness Equity Center at the same institution. He has a very long list of accomplishments and activities, which I'll go through some of them. He is the director of the Columbia University Global Mental Health Implementation Science Postdoctoral Fellowship. Also director of the Portuguese-speaking African countries mental health implementation research training program, co-director of the capacity development of HIV and mental health research in Asia, and founding chair of the Caucus of Global Mental Health and Psychiatry of the American Psychiatric Association. And he is also medical director of the Columbia University HIV Mental Health Training Project. His research focus includes global mental health implementation science and the intersection of HIV prevention and care with mental health and substance use among diverse, vulnerable populations in the US and globally. So please welcome Dr. Wainberg.
Thank you so much, Judy. Thank you, everybody, for joining. I'm going to share my screen. And as I'm saying that, it's a pleasure to be here and hopefully help process the beginning of many things. And in a way, what I'm going to present is a little bit of that. So I'm going to talk about the burden is high. We have effective treatments, yet we are in not very good shape. So this is just a few of the people that I love playing with. And we'll see, maybe some other will join along the way. But I'm very thankful for this amazing village all over the world. As you can see, we have US, Brazil, Mozambique, countries in Asia, etc. So burden and early mortality. So this is what we know about both sexes, years 15 to 49, in years lost for disability, and mental disorders are #1 in every continent. And if you look at adding the years lost to life, which is combined with the disability to give a DALY, the mental health disorders are either #1 or #2 in all continents. So what we know is that they're the leading cause of disability worldwide for both sexes and entire lifespan. And people with mental and substance use disorders experience physical health and have an average life expectancy that is 15 to 25 years shorter than that of the general population. So this is very complicated. However, despite evidence of multiple effective short-term psychotherapy treatments and medications, henceforth, I'm going to call them evidence-based interventions, that reduce the impact of mental and substance use disorders, no reduction in the global prevalence or burden was detected since 1990s. In all those years, we have not been able to move the needle to a better place. So the scaling up of evidence-based interventions has not been a priority globally. So if you're a mental health specialist, this is the number of people that you should be seeing to be able to provide care according to what we have nowadays. So you should be seeing 2 million people. So we're very busy if we would be seeing all of these. And the reality, the ideal number is considered to be 45 over 100,000. Low and middle income countries have 0.1 psychiatrists and 0.3 psychiatric nurses for 100,000 people. The US has a little number of 13. Switzerland is closer to the 45, and the rate of psychiatrists is 120 times greater in high-income countries than in low-income countries, and 75 times greater for psychiatric nursing. So what we see is that there's a complicated business here. That leads to a mental health treatment gap that is vast. So in high-income countries, 35 to 50% of people do not get treatment, whereas in low and middle-income countries, between 76 and 85. So we're really talking about a disaster, a very huge treatment gap. So in the US, I can tell you that we're supposed to be a high-income country, half of the people diagnosed with mental substance abuse disorders lifetime get care. So, sorry, only half of them get proper care. So a friend, Brian Pence, did trying to look at using the cascade that has been used in HIV to look at prevalence, recognize any treatment, adequate treatment, and achieve remission. This is how bad we're looking. By the way, in HIV, they're trying to do 90, 90, 90 here, and we're doing 6%. And if we're talking youth with depression, and this is just for depression, by the way, they're not identified by their providers and don't receive care, the majority of them. So the global, that I also call local in the US, mental and substance use disorders treatment gap is huge. So the current system of care offers, in primary care, maybe if doctors are allowed to prescribe medications. This is what happens in most high-income countries. They prescribe antidepressants and anti-anxiety medication. The rest goes to mental health specialists and tertiary care, acute care, emergency department, and inpatient. And what's the consequence of that? The shortage of mental health providers renders there's patients waiting for months to have access. So for example, once a patient, always a patient, we see people weekly or in therapies forever, which then takes the chair forever instead of figuring out a way to share what we have. Even if it's enough providers that can be available, reimbursements, at least in countries like the US, where it's terrible for mental health, creates more shortages. The training of mental health doesn't have a public health model or lens. We're all trying to see patients chronically, even if trained, to use short-term treatments. And we do one-on-one. We only think about how do we treat each patient. System of care is not organized for services to use short-term treatments, and not every patient needs to see a mental health specialist. And the step care model is something that it's indicated, and I'll talk some more about it. There's then another important data that shows that here in the US, 60% of patients drop out of treatment only 4 to 6 sessions if they're within the mental health sector, and if they're within the general medical sector where there is perhaps mental health social workers, etc., 3 sessions. So what this says is that 60% of people need to be seen for a very short period of time so we can engage them in care, and we don't. Some of the ways to address the challenges, we have task shifting and task sharing, which is mental health specialists train non-specialists to be the people who provide care, and it's according to their training what they can do. And there are many studies that show that lay workers can do that successfully for evidence-based interventions, short-term. And also integrated care. We always started before with consultation model and referral, then co-located, and then the integrated care model. It's more successful in providing care. And the step care model, that individual needs are matched to the appropriate level of care. More intensive intervention is only used if required. Not everybody needs to see the psychiatrist. So in this step care model, what we're trying to do is that more specialized and expensive treatment for complex cases are done by the step 4, which is psychologists and psychiatrists. A stepping up criteria is utilized more intensive and expensive treatment, and low intensity, cost effective, least time consuming, and as in the first line, should be done by people who are trained to do the good work, supervised by this group. So you have some self-help that can be done, evidence-based interventions by lay personnel, nurses, social workers, then medication management can be done for depression and anxiety at primary care, and then complex cases by psychiatric care. So mixed results, primary care providers, the mixed results portion is about collaborative care. Primary care providers in large public health settings are overwhelmed, and they don't want to be treating more patients for other disorders besides what they're doing already. So it's a complicated business. So the reasons for the vast mental health treatment gap, except for medications and procedures, few evidence-based therapies make it to the real world. In low and middle income countries, most medications are not available. In the US, insurance coverage limits availability. We're trained to address the health and mental health of one patient at a time. The public health lens is missing. There are not enough providers to reduce the gap. Mental disorders are hard to screen for. Training in evidence-based therapies takes time and supervision, but it should be done. And if it's done, it is a successful, effective method. Multiple stakeholders and funding must come together to make this happen. Stigma and misconception of mental illness as considered it as a weakness instead of as a disorder. It's a problem because then we don't feel that it belongs in the health system. And the science of bringing research to practice is young. So we discover a lot of wonderful things, but we don't bring it to the real world. And research focuses on one disorder at a time, which complicates even more. And I'll explain some a little bit later. So what can science do? Perfection is the enemy of progress. So if we have to do everything perfect, our children are never going to get education, because are we sending them to the perfect school for them to get education? The same thing is with here. There's some things that we know plenty, that we have rigor, and there's need, and how do we balance that? So this is what has been discussed, why implementation science is needed, because it takes an average of 17 years for 14% of evidence to be put into practice. Mental health interventions has worse numbers, because we're talking about training, for example, research psychologists to do evidence-based interventions, and for those trainings to be done outside is much more costly sometimes than offering a medication. So how does the health research continuum take place? Just so we know, we do epidemiological studies, so we find out what's taking place in settings. Then there's basic science, safety science, and efficacy to be able to determine if an intervention is ready to be tested for effectiveness, and then implementation. The only problem is that this is a long road, and we do one disorder at a time. When we start with these things, we tend to do depression care, anxiety care, OCD care, psychosis care. Whereas when we get to the real world, there's a mix of these things. So we have a real oive in Yiddish. That means, boy, this is complicated, because how do we do all of them? And this is, one study that I'll tell you some more about it, where we work with 1,364 in the sample. The comorbidities are high. And by the way, when I put common here, is a combination of depression, anxiety, and PTSD. So even within some of these, I already have combined of disorders, and severe, for example, is bipolar disorder and psychosis. So the comorbidity is the norm. So in most research studies, when we do, for example, depression care, we're always looking at patient outcomes, which is super important. You want to decrease the depression, right? And it's looking at the clinical effectiveness. The question is this enough? Because what I've been talking so far is the inability for us to really get to the patient to provide those patient outcomes. So it's important to look at services outcomes. Do we do an efficient way of doing things? Is it safe? Is there equity? Are we seeing just the cousins of the people who work in the clinic, or are we seeing the population that is really in need? And the timeliness, people should not be waiting for months to be seen. And then after that, we also need to look at what we're trying to implement. Is it acceptable? Is it feasible? If I train people and it does it stay? Is there uptake? Is the fidelity to the intervention appropriate? And we need to look at cost and sustainability to make sure that it stays. This word sustainability is one of, I always tell all my students that there are three words that I want them to remember. One is sustainability, the other one is sustainability, and the third one is sustainability. That nothing that we do should just be a paper, that it should also have sustainable impact. So an efficacy trial, as you all know, randomized, intervention control, hopefully the intervention is good and the control is not as good, but how do we bring this? Who's doing it? Why is it doing it? Where are we doing it? So it's a complicated, where we're going to, the implementation of this it's still not there in the efficacy trial. The same thing in the effectiveness. We may have a little bit more variety in the intervention, but we still don't know what are the needs to make sure that the intervention be adopted, uptake, be done with fidelity and rigor, and would be sustainable. So it's important to figure out who's going to do what, and that's where implementation science comes in with strategies to do that. And very quickly, where does implementation science come from? There are factors associated with adoption and diffusion of innovation. Rogers wrote about this. And there's some people who, when something new comes in, they're the first one to do it. Then there are the early adopters who follow, early majority who do, and then the people who are, I'm going to wait until all my friends are using it before I prescribe this medication. And then the people who stay with whatever they're doing, and they do whatever they're doing no matter what. So And, if some of you are prescribers, you even may look at yourself and your behaviors within these. Do you prescribe immediately? Do you do it? Do you wait for some people to do it for you to do it? Or are you on the late side? And I'm not going to ask you if you're a laggard in that situation. So the goal is to increase those who are in the green to yellow and decrease the ones in red. So all of this is in the reality that any evidence-based intervention that gets produced gets put within a system where you have a patient and a provider. Both of them have to want to do it. They would want to be part of it. They would be acceptable. The organization has to be in agreement for that, and the structure of the system also needs to allow it. It cannot be that just a provider decides, I'm going to do this, with the system not being in that. And the structure in all of these is within a setting that where there are norms and also socioeconomic and political context that has an impact on that. Because if there's no funding, for example, to do this, because of issues of stigma and other elements, it becomes complicated to bring evidence-based interventions that we know work into the system. So implementation science is trying to do an active way of adoption. The way we researchers do work, we do the work, we're very happy with what we did, we do a paper and then present in conferences like this. That doesn't mean that it's going to be adopted. So it's looking at about active strategies to make sure that evidence-based get into the real world to decrease these 17 years that I talked about. So let me tell you a little bit about the work that we do at Columbia. We have a fellowship with postdoctoral fellows working in all of these countries. These are amazing people, and I learn from them. And the goal of this fellowship is not only to collaborate with local or global places where mental health treatment gap is high, but also help with the research gap in collaboration with other countries and make sure that they have a career for them to continue doing their work. Then we also have global partners, and I'm going to talk of the blue and the purple and the green that are here because are connected to, it all started with a Fogarty grant, like the one that it's starting right now, that Christina and all of you are doing. It started with that and led to very big, 2 large studies, and then we're trying to replicate the same thing in Asia. So let me tell you a little bit about Mozambique. Mozambique is between 4th or 6th poorest country globally, depending on the year. And it's 70% rural, 90% within 1 hour of primary care clinics, which is a good thing. HIV rate is high, depending on the region. The public health system is free for all community-level primary care clinics. There's no mental health care. And it's also important to understand that these community clinics do not have physicians working there. So when the antiretroviral rollout took place in sub-Saharan Africa, there were not enough doctors to provide care to all the people with HIV in the country when you have 9 to 19. So what they did is that they created a new cadre of physicians that they're called medicine technicians, not physicians, of healthcare providers, who are trained to do primary care, and they are supervised by physicians and provide care for everything: malaria, perinatal, HIV, TB. They are, and I've trained them and I've worked with them. They are amazing. They want to make sure that people understand that they are the doctors of the community and they do an amazing job. And there's also urban district and provincial level clinics and hospitals, of course. The public mental health system, it's only in the urban areas, as I mentioned here, with specialty clinics. There's about 600 providers for the 29 million people. The mental health system in Mozambique created using the same strategy that I mentioned for HIV, psychiatric technicians, without money, by the way. HIV had a lot of funding from PEPFAR and other funding. And the psychiatric technicians provide care, but only at the district level, still in urban district level. So 70% rural areas lack mental health care. There are about 150 psychologists and 18 psychiatrists at hospitals. And there were no validated mental health measures when we started our work in 2014. So the treatment gap is humongous. So how did we start our work? Once we had the Fogarty grant, and we had fellows that included the director of mental health for the country, which was amazing. In the Fogarty capacity building grant, each fellow needed to come up with a pilot that they would be working on. And of course, from the 11 people we had, some were doing depression care, perinatal depression, depression and HIV. The director of mental health of the country was having a little bit of a harder time. She says, I'm in charge of the country. I cannot do a little study. So working with policymakers to determine priorities was our biggest success. What are the most common mental health problems? How will we identify those in need of mental health services? Where might services be implemented? What interventions are contextually appropriate, looking at acceptability and feasibility. So Lydia Govea, who at that time was the director of mental health for the country, her problem was that they have trained psychiatric technicians. There were a few, and it was easy to supervise them. And as they grew, they provide better access in rural areas, and still there was how to ensure the quality of care. So she was very concerned that as they were growing, how would they going to make sure that there would be a good clinical supervision? And thinking together what to do, came our plan that we needed to try to come up with a little bit of a different step care model. So there's obviously community self-help, then evidence-based interventions could be based on evidence that lay personnel can do it, then evidence-based interventions could do it. Medication management would be by the primary care providers. And we're talking all medications, right? Not only antidepressants. And only the complex cases are done by the few psychiatric technicians and psychiatrists that are in the country. Obviously, these people supervise all the care, and the mental health specialists also are part of these engaged in this process. So the idea is to really move everything to the community, to primary care, community care. And we put together a very large study. And our study is the first one ever to do comprehensive mental health care, where we do all disorders. We're providing evidence-based interventions for all treatments and medications. We started with a sample of 40,000. We realized that there was going to be a huge contamination. So we had to move it to 7 million. So I'm not going to tell you how many people we're going to have, because we're in the process of doing it. And I've lost a lot of my hair, as you can see. The study has 3 arms, the normal district level. Then we wanted to look at 2 implementation strategies. With the care at the clinic level would be the best one, meaning everything happens, community health workers screen, but all the treatment happens by medicine technicians. And in pathway 3 would be the combination where the community health worker does the evidence-based treatments and the clinic providers do the medication. We're going to be working in 3, 5, and 5 districts, and this is more or less the number of community health workers that we're training and the number of families that they have under their care. So the way the system works, you have a community health worker that is in charge of an area where there's between 250 to 400 families that they have to visit at least once a year. They work a lot. They provide malaria care, HIV, TB, perinatal, diarrheas in children, et cetera, et cetera. They live in the community and they're respected by the community to do this work. So because we were thinking of doing, as I just say here, comprehensive mental health care, we needed to come up with a way to provide, to screen in this low resource setting, right? And I met with the director of the community health workers, and I asked him, because I know that these community health workers have so much to do. And I asked him, how many questions can they ask to address mental health disorders? And he said, well, 3 to 6. And if you think about psychiatric disorders and screeners, we're talking a big number. So we needed to come up with a new method. So we needed to identify a wide range of psychiatric disorders, from depression to psychosis and substance use. It needs to be very brief, to be implemented by community health workers as part of their in-house primary care drop-in. It needs to be reliable and valid with direct interview and proxy informant, meaning community health workers don't interview each person in the household. They use an informant to get information about the others who live in the household. So how's, Maria doing? Is anybody pregnant since the last time I was here? How are the children doing? So there's an informant that it provides information about the rest of the file. It needs to be able to screen as well as triage, sensitive to identify any mental health problem and specific to triage to specific disorders. So basically the idea was that we knew what treatments that we had chosen through the D43. We chose we work with the local mental health team to determine what would be the best interventions to adapt and prepare for this intervention, for this study. So they chose interpersonal counseling for common disorders, medication for severe disorders, safety planning intervention for suicide risk, and motivation interviewing for alcohol and drug use. So we needed to come up with the best screeners. We were looking at all these disorders, and we're also looking at functioning for the HUDAs to see if we can get also functionality, because as you probably will know that any psychiatric disorder besides symptoms that are demonstrated by these screeners, they need to show also, we need to know that you have impairment and that what becomes a disorder. So our goal was to really treat disorders, not to treat mild stress, because the system needs help for people with disorders that are getting nothing. So we had 99 items, and the idea is how do we, looking at the mini diagnosis, the mini international neuropsychiatric interview, to be able to figure out what would be the minimum number of items to ask. So we use this method called LASSO, the least absolute shrink and selection operator, to do a logistic regression. And then we try to decrease 3 to 3, 5, 8, and 10 items to best classify disorders. We didn't just do this. We decided that instead of just letting the computer and this LASSO take the lead, that we would also have expert consultation to select combination of items that would be best for the different disorders. So, I am blessed with being at Columbia, so we had the opportunity to meet with experts in each of these disorders to make sure that we would all be happy with what we came up with. So we did a developmental, where we did the adaptation of all the measures. So then we did the development of the measure and then the validation of the measure with all these patients. And as you can see, there's a variety of disorders. We included somatization because there's this common thought that somatization is a way of addressing, looking at depression and anxiety. We didn't find it to be that strong. And then I showed you this before that allows us to realize what was the distribution within the sample that we had. And this is what we were able to come up. We came up with a tool that we can describe any disorder with a very high sensitivity asking you. And then we can categorize using specificity for the common substance use and suicide. And for this one, we increased the specificity by then looking at specific disorders. So for example, this one captures any psychotic disorder and bipolar disorder, which is very broad. And therefore we increase the specificity by adding by the specialist or the mental health provider or the primary care provider doing a more specific diagnostic interview. We were very lucky that also the proxy worked very well, not with a non-family proxy. So people were able to identify with 73% sensitivity. So above 0.7, it's considered very good, and that it's a good thing to have. So by asking one person about the rest, we would be able to identify. Because this is a country that has a lot of HIV, we're interested in figuring out how it works with people with HIV and without HIV, and we felt very comfortable that we can do it with either or both. And we also thought that, the PHQ-4 is being used, which is a combination of the first two questions of the PHQ-9 for depression and the first two items of the G87 for generalized anxiety disorder, and our for the three items that allows for any disorder, it has an item from the PHQ-9 and two from the G87. So these are the questions that are being done that we use. So we wanted to see how they perform because the PHQ-4 is being used in many places. And we find out that the mini anxiety and the mini depression both do a very good job with sensitivity to determine that people have either depression or anxiety, either with the PHQ-4 or our tool. And with people with HIV, we had exactly the same results. We had a good sensitivity to pick up for depression and anxiety using either the PHQ-4 or our tool. However, we believe that our tool has a few advantages because, number one, the three would allow you as a first step to ask a few more questions for those that are positive to determine if they have specific disorders. So it's a triage at the same time after that. And one of the things that we know from collaborative care in the US that a lot of people with minor psychosis, that their psychosis is not that they're hearing voices and everybody and talking to everybody. So psychosis can go underdiagnosed and it looks like depression because people are more on the quiet side. So the versatility of our screener has acceptability for any disorder. And at the same time, when a family member asks the average about each individual, and it's briefer. It's 3 items against 4, which is it makes a huge difference. So how does this work? So the community health worker visits a household and speaks with the informant and asks questions about the people living in the household. And this is the normal care that takes place with everything else. So we decided that we needed to work with that. Number one, we're looking also right now at what are the social determinants of health for this and figure out what could be social determinants interventions that we are looking into. And this is work that we're doing both here in the US. But I'm going to concentrate on the 3 questions about each household member. Then from that, we identify the person that may have any disorder by proxy. And in step 2, the community health worker then this person that has been identified asks the 3 questions ending, and the sensitivity increases to 94%. We know who doesn't have a disorder. And in step 3, with 9 additional questions, we can diagnose categories, and we then can triage to evidence-based treatments. And the important element about all of this is that this is all in tablets or in a platform where the person asking the questions or providing the care gets guided in a very rigorous way. And we have a way of knowing if the community health worker or the provider is using the tablet properly, because you're supposed to stay in a frame, for example, 3 minutes. And if you stay 20, we know you're not using it. And if you stay 10 seconds, we also know that we're not using. So we have a metadata way of knowing if people are using the system properly. At the same time, of course, we have clinical supervision. So we have a couple of innovations. It's sustainable. It leverages existing resources, and the research funds are only used for training. We trained a local cadre of trainers and supervisors, so it's sustained. And technology also remains post-study. It's the first study to do comprehensive mental health care. Most of the other studies do 1 or 2 disorders. The tool that we're using is novel, brief, efficient, and valid method to identify cases and triage them. And all interventions used are evidence-based. We examine how to incorporate short-term treatment within a system of care to treat chronic conditions, so they can be used in a sequential way. So, for example, because comorbidities are the norm, you can start with 1 treatment and reassess and then go to the treatment or combine treatments, and addressing severity and patient choice to make the decision. It's 100% shifting, sharing, and step care coordinated by mental health specialists. So the providers are community health workers and medicine technicians, and the supervisors are psychiatric technicians. So the way it works, the person comes and visits, talks to individual, and is able to provide information that immediately gets connected through the system of care. So this is just a quick look how the tablet looks. So ESPER is for alcohol and drugs. So they're asking questions to determine how people are drinking or using drugs. And then there is a determination of where people are. There's a lot of psychoeducation, and the community health worker can click here and explains how the different organs are affected. And wherever there is this eye here in orange can be clicked, and it will remind the provider if they're a little lost of what they need to do here. Interpersonal counseling, which is derived from interpersonal therapy. It has been used all over the world. One of the main issues first is to understand the sick role, that this is not a weakness, you have an illness and we need to treat it. Another element of interpersonal counseling is understanding the interpersonal life of people, and to make an inventory of who's in their life, and also if they are connected in the distress or in the distress. So it's to understand how they are actually people that help them or actually make them feel worse. And we also have a way of understanding where trauma is connected. And then we use the circle to figure out how close these people are to you and to determine who to play with and how to ask for help. These are the selected areas that are part of the problem areas of interpersonal counseling. There are grief, disputes, life transition, and loneliness. In the disputes, we have a section for trauma. if that's something that people are going through. And safety planning intervention for suicide, we start first by ranking again where the people are with regards to suicide. We want to make sure that we're safe. So we ask the 6 questions that are here. And according to the answers, we may have suicide with a risk level of low or high or in the medium. So if it's low, we still ask again. We want to make sure that the person feels has a second opportunity to talk to us about how they feel. If it's too high, then we have a rescue protocol. If not, people go into the application where there's some psychoeducation first to understand that suicide is a transition. It's not constantly up there. And their safety plan has 6 different areas where it works. Warning signs, internal coping strategies that the person already have, people and social settings that provide distraction, family and friends who may offer help, and professionals that can help in making the environment safe. So I put 2 of them over here where the person goes through with to mark what are potential thoughts or emotions, and if they're not there, the person can include them. And this gives the provider an idea of what's taking place. And for example, in making the environment safe is the methods that you use, safety in the methods that the person may be using for their suicide. So what we know is that evidence-based interventions developed in high-income countries have been contextually and culturally adapted, what we did, tested, and some have been replicated in multiple countries, low and middle-income countries. However, the data on how to deliver them is extremely limited, including high-income countries. And I created this table to try to look at system-level factors, health system-level factors, and context-level factors. And I put over here on the tab low and middle-income countries, high-income countries, where 1 is poor and 4 is excellent. And there's some things that obviously high-income countries are doing better: epidata, validated tools, efficacy of interventions. However, when it starts getting into effectiveness and implementation, the high-income countries, and to do for more than one at a time, are getting very close to the treatment gap that we have in low and middle-income countries. Health system factors, specialty clinics, primary care, perinatal services capable of providing healthcare. Again, we are not that good in high-income countries. Psychotropic availability, very good here. In some countries all over the world, if you're not a psychiatrist, you cannot prescribe. Trained mental health specialists, we're not good. We have a very low number, remember, 13 instead of 45. No mental health providers trained to provide mental health care. Again, it's very low in our country and much worse in low and middle income countries. Community health workers, we're doing actually worse than what's happening in low and middle income countries. In the US here, doing worse. And the interventions being utilized in the health system are not part of the reality globally. Education and training mental health providers includes public health lens. Again, we're trained to treat 1 patient at a time. In the context level factors, we have funding, mental policies, digital infrastructure to use the new possibilities of technology, and mental health stigma. And we're not doing that great. So basically, unfortunately, low and middle income countries have a lot of suffering, but there's a lot that we also need to do in high income countries. This is a global reality. So the work that we did in Mozambique, we created a collaboration and partnership to bring evidence-based treatments and see how to adopt them, implement them, and adapt them for Mozambique. And now we're trying to bring it back, because what we were able to do in Mozambique, it hasn't been done in the US. So we're doing a pilot in New York City to figure out how do we use this technology. And we're planning on the scale up of our work in New York State and the Mental Wellness Equity Center, that it's our next wonderful work, will include training, services, research, and education to make sure that mental substance use disorder disparities within the US populations that experience it are decreased, and we're going to try to address issues of education and training in the health system. And we're also going to be looking at financial wellness everywhere, addressing social determinants of health. So how it's going to work here, you already know the top because I explained to you, and we're going to use a financial wellness tool to then try to come up with wellness care with regards to finances by also lay personnel. Thank you for your attention.
Are there any questions?
I have a question. I'm Lakshmi Vijay Kumar from India. Hi, Milton. That was a wonderful.
Hi, how are you?
Good, all good. I just have a question. In your screening question, you say that you also ask about the suicide. So it is part of that 4 questions, or is it a little different? Well, how
So-
do you screen?
What we do is as following. We first ask 3 questions. If the person, which are part of the PHQ and the GAD, so they're very comfortable questions to be asked. If the person is positive in any of them, then we add the 9 questions that includes questions of suicide.
Yeah.
But we,
Mine is suicide. So initially, you don't ask the question for suicide. If somebody screens positive, only then.
correct.
And my next question follows up that is that in many situations in low and middle income countries, many people don't express a depressive or an anxiety symptoms, but may have suicidal ideation. So how do you handle that?
So you mean that people, so when we did I think the question is very good. Not everybody necessarily that have suicidality has depression, anxiety, PTSD, or another disorder. And actually 15% of our sample did not have another disorder, which clarifies exactly what you're saying. So the first 3 questions are just screeners. They're very open screeners. They do not give a diagnosis. So there are people who will screen for any disorder that includes suicide. And then they will be categorized either for a common, severe, substance use, and suicide risk. For suicide risk, we do safety planning intervention regardless of where they're at with other disorders.
No,
And
I
then-
get that. What I want to know is, in the screening questions, if you don't have anything specifically on suicidal ideation or anything, then there is a likelihood of missing that, isn't it?
Well, our data doesn't show that. Let me explain, because the way that we came up with the screeners is that, remember that asking about distress is part of what suicide could be, or asking, so the questions, and I can put the questions to see if you feel comfortable. Let me just take you to where I have the 3 questions. Okay, let me quickly share my screen. So as you can see here, well, you cannot because I have animation. So it's about feeling down, depressed, or helpless, feeling nervous, anxious, or on edge, being so restless that it's hard to sit still. So these 3 items are not items that tell you have major depression or anxiety disorder. They're just 3 items. And we found that they were present even among those people that only had suicidality. That even if they don't have, because this doesn't necessarily qualify for a disorder. This is just for any.
No, I know. But okay. Okay. Thank you. Thank you, Milton. That was wonderful anyway.
You're welcome. Thank you.
I just wanted to clarify, having had the opportunity, have you had the opportunity to do the surveillance in Mozambique for suicide, which we sent the papers to you?
So we are implementing this study, and in the next few months, we're going to be doing the surveillance all over, and we're collaborating with some friends of yours to do, because we're developing the same measure for adolescents, and we already developed the measure. Now we have to validate it, and we're hoping to look at it in other countries, so we have a little bit more of variability. Thank you.
Thank you very much.
Thank you. Yes, hi, Hi, Christina.
Milton, like in Guyana, right?
Yes. That's it. Well, thank you, everybody.
Okay, are there any other questions before we go?
Very impressive work, Milton.
Thank you,
Thank you.
Lena.
Thank you so much for a wonderful presentation, and thank you.
Thank you so much, Judy. Thank you, everybody, and good luck with all the endeavors in Guyana. Bye-bye.
Okay. Bye-bye.